you. So let me just welcome everyone to RNO's virtual dialogue regarding RNO's end-of-life resolution. I have on the line Dr. Vanessa Burkowski, RNO President, and at home office is Dr. Doris Grinspan, RNO Chief Executive Officer. Thank you for joining us today, everyone. If you haven't already joined the online webinar, please do so because the presentation slides will be viewed inside the webinar. We currently have 146 people online in the webinar, and we're also, if you've only joined the teleconference, you'll be able to hear the audio portion, but you won't be able to see the slides. So please do join the webinar. And because you won't be able to speak on the teleconference line, we ask you to please your questions or comments in the chat box inside the webinar. This should be located on the right-hand side with the slides taking up most of the left-hand side. We're monitoring the chat box submissions, and we will respond to them accordingly.
Very good. So we have time from now till 7, right? So hopefully we will spend over half an hour or a little bit, no more than that, on the presentation, which Vanessa and I will take turns in doing, and then we will leave the remaining of the time for dialogue because that's actually the intent of the resolution. Let me tell you that we already have close to 160 people. I think you all can see how many people we have, but we can update you if that's not the case. Let me begin by saying that the end-of-life resolution that was passed by a large majority at the AGM is one of many activities that RNO is undertaking. And just to remind people that are perhaps not as familiar with the strategic directions of RNO, the board of directors of RNO has 4 strategic ends. The first one, engage with RNs and nursing students to stimulate membership. The second, advance the role and image of nurses. The third, speak out on emerging issues. And the fourth, influence healthy public policy. Of course, it goes without saying that the end-of-life resolution has very much everything to do with speaking out on emerging issues. As you may know, most of you, given your interest on this specific resolution, the Supreme Court of Canada is, as we speak, dealing with the issue of end-of-life. Let me just bring you up to date a bit with the latest, the past year accomplishments of RNO. In addition to this resolution, membership engagement and capacity building has been higher than ever, both in terms of events, webinars. If you think about ECHO, if you think about primary solutions to primary care, if we think about RNO's vision, the engagement through these webinars has been tremendous. And we appreciate the amount of people that have attended, including now that already that we are at 175. Political engagement and hence the influence of RNO is again tremendous. Last year alone, we had direct interaction with 104 of the 107 elected MPPs. And this year in the Queen's Park on the Road, we already surpassed 70. So I expect that we will see, again, over 100 MPPs that we will be visiting throughout this year. Media presence, as you probably have realized in the last few days, just in the last day alone, we were quoted more than 40 times, whether it was television or radio, etc., on the issue of the Ebola. Similarly, on the issue of medical tourism, end of life, etc., whether it's Twitter or whether it's media, we are very much involved. Influencing government on deliverables, again, very, very much involved. And in terms of the membership, I am happy to say that although we scored the highest last year with 30,000 RNs, NPs, and nursing students, we already surpassed this year, at this point, the 40,000. So the membership is crazy but phenomenal speed. And this is due to the fact that we very much are the voice for RNs, NPs, and nursing students in Ontario on the critical issues facing the profession and facing health and healthcare. I want to also share with you that on the of BPSOs, we had the Nova Scotia joining, and now we had South Africa joining others. And of course, we launched a database that is guiding not only nursing, but many other aspects of healthcare in Ontario and the nursing codexes. Let's move now from this broad background to actually an update on RNAO's end-of-life resolution that brings the voice of RNs, NPs, and nursing students to the forefront. So patients and families are making passionate pleas to ignite national discussion on dying with dignity. All three provincial political parties have been engaged in one way or another on these discussions. The Supreme Court of Canada is not just preparing now, but actually began the hearings in relationship to the constitutionality of prohibitions on the issue of provider-assisted suicide. And for those of you that are following the debate, it's a very interesting and intense debate that is happening between the federal courts and the Supreme Court of Canada, and many groups are involved in providing their views. And RNAO is constantly being asked by the media and stakeholders to contribute to the discussion, and that is why our board of directors actually put the resolution forward, because the voice of RNs, NPs, and nursing students and the respect that RNAO has garnered through the year from both politicians and the media and the public at large behooves that we be involved in these discussions. With that, let me pass the actual resolution to our president, Dr. Vanessa Burkowski. Vanessa, on to you.
Thank you, Doris, and hello, everyone. You'll have the RNAO resolution in front of you, but let me walk you through the pieces so that we can ensure clarity of discussion as we proceed. So the resolution starts with the national discussion that, as Doris already alluded to, is already underway regarding end-of-life care, and there is specific emphasis on dying with dignity, which involves a review of assisted suicide and or euthanasia. And whereas the final decision on permitting assisted suicide and or euthanasia rests with the public, and I think that this is critically important because it is the public that is bringing attention to this issue, and it is the public who is asking for direction and support in their quest to have a national discussion in relation to this matter. And whereas there is support from all three provincial political parties to engage in a discussion regarding end-of-life care, and whereas RNAO is being asked by stakeholders and media to comment on this issue. So the resolution is, therefore, it be resolved that RNAO urge the provincial and federal governments to engage in formal public dialogue on end-of-life issues and dying with dignity, including discussions related to assisted suicide and or euthanasia. And therefore, it be further resolved that the principles be considered when discussing assisted suicide and or euthanasia. And the principles are inclusive of personal autonomy and justice, which are fundamental, ensuring timely access to evidence-based palliative care, which must remain a top priority. The government must reject calls for involuntary euthanasia. Therefore, it be further resolved that the following principles be considered when discussing assisted suicide and or euthanasia. Assisted suicide and or euthanasia must never be considered within the context of cost savings. Procedural safeguards must be enacted, including restricting assisted suicide and or euthanasia to competent adults with terminal illness, requiring that requests for assisted suicide and or euthanasia be initiated by the person seeking the service and would be subject to a thorough review process that includes independent confirmation of terminal illness, determination of capacity by a mental health care professional, with appeal to the Consent and Capacity Board, if necessary, providing access to all reasonable alternatives, and establishing a waiting period. Therefore, it be further resolved that the following principles be considered when discussing assisted suicide and/or euthanasia. The practice of assisted suicide and/or voluntary active euthanasia must be restricted to professionals who have sought designated education and training. No health professional or organization should be required to participate in assisted suicide and/or voluntary active euthanasia. And a provincial monitoring and reporting system must be developed, including a process for responding to complaints. Consultation representatives, supported by a large majority vote, a resolution from RNAO's Board of Directors at the 2014 Annual General Meeting calling for the formal public dialogue on the end-of-life issues and dying with dignity. So I don't know if we should pause there if you want to speak specifically or we want to open it up to questions about the resolution, or if we want to talk a little bit more about RNAO's contribution and why we should be involved.
First, finish the whole presentation, I suggest.
Okay.
Yes, and then open for questions.
Okay, very good. All right, so why contribute to this public dialogue? Well, the voice of registered nurses and nurse practitioners is a reliable and expected source of information from the public. The public wants to hear from us. I think there are many occasions in which RNAO has provided presentations on the public level of trust in nursing. It is always at the top of the public's mind that nurses can be trusted, that nurses are the public advocates. And number 3, speaks out on emerging issues that impact on nurses and the nursing profession, health, and healthcare. This is one of the ends that we espouse to at RNAO. And end number 4, influencing healthy public policy. If we are not involved in the conversation, then public policy will be developed outside of us. The conversations, again, are already happening, and we need to be able to influence the appropriate the policy in a meaningful way. Competing priorities. There are a number of competing priorities, including human rights, autonomy and self-determination versus justice, non-maleficence versus beneficence, critical interests versus experiential interests, capacity in vulnerable groups, moral and religious grounds. There are a number of priorities that will need to be considered, that will need to have effective dialogue on, and nurses are positioned to provide insight as well as evidence-based information to support the conversation. A principled approach. An opportunity exists to apply a principled approach to discussions about dying and dignity. A principled approach suggests that discussions surrounding assisted suicide and or euthanasia rest with the public. It is not any sole government or association or private group that can make this decision. It is really a dialogue that needs to occur with a multitude of stakeholders and with the public. Registered nurses can offer principles for consideration, respecting self-determination, and identifying safeguard parameters. We are experts in delivering care. We are experts at advocating for patients, families, and the public. Next steps are to engage with members, politicians, and the media to advance the formal public dialogue on the end-of-life issues and dying with dignity, including discussions related to assisted suicide and or euthanasia. Doris, as you know, is actively involved. Not only Doris, but the RNAO Home Office is actively involved in communicating messages through Twitter, and I would encourage all of you to follow the Twitter leads that Doris passes along to RNAO. Do we want to open it up for questions now, Doris?
Absolutely. I think that we may have some. Josephine, can you read them for us?
Yes.
And we can take turns. Vanessa, if that's okay?
Sure.
And I would suggest to protect the confidentiality of people. If do not mention the names of who is approaching, they can mention unless they are saying, please say my name. Otherwise, I just suggest let's go without names. It doesn't really matter who is saying whatever. Whoever is saying is important.
Sure. Okay, so the first question, RNs are providing care even when patients are terminally ill. So when they have pain, we should offer proper support and care, including the medication. Why is RNAO not actively promoting palliative care and support for individuals terminally ill?
So let me comment on that. RNAO actually is absolutely promoting palliative care. RNAO also has a guideline. One of specifically, we developed the last hours of end-of-life care. So not only we are supporting actively politically and policy-wise palliative care, we are also supporting the issue of best practice guidelines on it. So the answer is yes, we are. Nothing is instead, and always, even in countries, just so you know, given the court and the direction that the Supreme Court is likely to take, even in countries where the issue of euthanasia has been open to public debate, the budgets for palliative care have increased significantly. That's the case actually in Belgium, where the budget increased threefold in palliative care. So RNAOs always will be pushing for equal access across the province in all regions and in all sectors and at home. Palliative care, that's a top priority.
It's Vanessa. Can I refer you to the resolution? The second component, therefore, be it further resolved that the following principles be considered when discussing assisted suicide and or euthanasia. The second bullet specifically refers to ensuring timely access to evidence-based palliative care, which must remain a top priority. It is a component of the actual resolution.
Thank you, Vanessa. You want to read the next one?
Sure. I'll read the next question. Can you confirm if you are speaking on behalf of all nurses, as you use the term nurses frequently, but nurses also includes RPN? What engagement with RPNAO on this issue have you conducted?
We are actually speaking on behalf of RNAO, and RNAO represents RNs, NPs, and nursing students, and the resolution was passed at RNAO. And at that resolution, the voting members are members of RNAO, which represents, again, RNs, NPs, and nursing students. This is who RNAO is.
Thank you, Doris. The next submission is a comment. Any euthanasia with qualifications such as age, health state, mental state, or who performs it can be challenged in the court. Okay. The next submission. My personal values and conscience cannot support assisted suicide or active euthanasia. I appreciate that I would not be expected to actively participate, but would I be held accountable to carry on a discussion with a patient about this, or can I defer to a colleague?
These are exactly the type of issues that will need to be discussed, and this is exactly why RNAO needs to be involved, because as you see in the resolution, we absolutely said it cannot be forced not only upon a nurse, but also not upon a physician. And also, equally important, is the framework that needs to be to protect people against their own will, both patients and staff.
If you also refer to the resolution, if you'll look at the, sorry, these aren't, I don't have the page numbers, but the fourth component where it says, therefore it be further resolved that the following principles be considered when discussing assisted suicide and or euthanasia. If you look at bullet 1, it specifically states the practice of assisted suicide and or voluntary active euthanasia must be restricted to professionals who have sought designated education and training.
And then it says no health professional or organization should be required to participate in assisted suicide and or voluntary active euthanasia. So, but your question, the comment of this colleague is very important because points out to the importance of RNO being involved in the discussions so that actually these parameters are integrated into whichever framework that may be developed.
Okay. Also part of the same submission is another question. When would a complaint against me be valid in such a situation?
I'm sorry, I didn't.
Oh, let me reread the whole submission. Sorry about that.
That's okay.
My personal values and conscience cannot support assisted suicide or active euthanasia. I appreciate that I would not be expected to actively participate, but would I be held accountable beyond a discussion with the patient about this, or can I defer to a colleague? When would a complaint against me be valid in such a situation?
I don't think that we can predetermine that. Our view from RNO, if we were to be invited to participate in these discussions, is that yes, you could refer that to another colleague if this is against your religious or personal values to have the discussion. No different than in other issues. Not every nurse feels competent or prepared to discuss dying even with people. So I don't think people can be forced or should be forced. But again, this demonstrates the need for RNO to be involved in this type of discussion. Thank you for the comment.
Yeah. If I may add one other comment, if you refer to the College of Nurses standards, one of the components speaks to nurses' requirement to declare when they feel there is a conflict of interest in delivering care to patients. And a component of conflict of interest may be that your values are misaligned.
Okay. The next submission is just a comment again and not a question. The comment is, okay, I'll just read it verbatim. So please, the terminology of suicide out of the discussion and resolution. Dying with dignity does not use this term.
So the resolution is what the resolution is. We cannot change the resolution that was passed at the AGM. You may remember that a few members tried to delete that from the resolution, and voting delegates voted down the proposed changes of taking it out of the resolution.
Okay. The next question, are the slides available after the conference?
Absolutely.
Okay, great. The question after that, why don't you have the palliative care nurses interest group presenting this with you as they are the experts?
Everybody was involved. The experts are all members on this. Everybody was involved. This is not about now discussing the specifics of where the Supreme Court will go and what our intervention will be if we were invited to the table. This is a discussion about the resolution, and it's the prerogative of all members to be involved on resolutions and of our president and myself as her support to actually present that. So it doesn't belong to one interest group, it belongs to all members. It's a resolution passed at the AGM. If we were to be invited to the table to have discussions, we will consult with all the relevant groups.
Okay. Would we also support the client who directs in advance, in writing, that euthanization or assisted be undertaken if they cannot communicate?
Again, those are aspects that will be discussed when the time comes, and at that point, RNO will basically say what the resolution says. The decision is with the public, and whatever the public will be dialoguing as a whole, that's where what we will. This is what this resolution is. It's not about RNO taking a stand. It's about RNO urging a public debate where the public makes the final decisions of what they want to see in legislation.
Okay. Dying with dignity and euthanasia are separate issues. Will these issues be presented as distinct issues?
Vanessa, you want to take it on? I responded this in a previous question already.
Dying with, sorry, read the question again.
Sure. Dying with dignity and euthanasia are separate issues. Will these issues be presented as distinct issues?
As a what issue?
Distinct issues.
Oh, as distinct issues. I mean that the resolution calls for the conversation of each of the components. I am not sure about whether or not in the process of consultation each component will require a separate and distinct conversation to develop it more fully in terms of bringing forward the kinds of further principles or details around each of the principles. But each of those components are part of the resolution and require public dialogue.
And each of the components, members wanted it to be there. Again, I want to remind people that at the AGM, there were a couple of occasions where a member wanted to delete the component of euthanasia from the resolution, and a large majority said, no, we want that there.
Okay. The next submission is the comment again. I feel that one must look at the patient as a whole and rather first look at the word dignity.
Yep.
Okay. The next
we all agree with that.
Okay. The next comment. The term terminal illness is no longer appropriate, although widely used. I would like to advise that the term life-limiting progressive illness/disease is now appropriate.
Yeah, and I mean, this is, sure, it's not what the resolution is about, but those are the type of debates that will come in the public, right? And in fact, I would strongly recommend that we follow the Supreme Court procedures, because these are the discussions that are happening. And then when the decision is made by the Supreme Court and there will be legislative changes or no changes, that's when these issues will come to be, and that's where you will want RNAO to have a voice.
Okay. Looking toward a future where dying with dignity is possible, what is the role of the RN in this life-ending experience?
I am not sure what the person means where it says dying with dignity. It seems to suggest the issue of euthanasia there. You may have seen that the CMA put a position statement where they want the flexibility for doctors to be able to assist people. RNAO has not put any statement, nor do we think at this point we will. All that the resolution speaks is about urging a public debate, because we believe that this debate belongs in the hands of the public. When you see the court proceedings now, there is a lot of debate amongst the public. That's the type of debate we want to see. What will be the role of RNs or NPs in the future? Time will tell. Let's not put the cart before the horse.
Okay. Is RNAO consulting other stakeholders or knowledgeable professionals regarding this resolution? For example, palliative care interest group. So,
again, this is not about, we are having these seminars. We have opened them to absolutely everybody to join. We have 224 people. Likely we will have another such webinar given the high interest. What we are discussing now is not any specifics, but a resolution that urges public debate. So the same as we are having the dialogue with you and all of our members, it's the same dialogue that we want the public to be able to have. And when specifics will be discussed and we hopefully will be invited to the tables, that's where we will have the more in-depth consultations. Vanessa spoke not only with palliative nurses, but other expert groups within the nursing family.
Okay. The next question is, can you please explain what designated education and training is?
Depending on where this will end, if it does end on aspects related to palliative care, which of course we very much hope that will be increased. Again, education and training in palliative care needs to be increased. If it's about assisted suicide and or euthanasia, the type of discussions that nurses may need to have with the public or listen, because the public may raise them, not because you may raise them. That's the type of education we are talking.
Okay. How do you plan to address the potential for inequitable access to the process? Should there be no practitioner in a geographic area that chooses to take the training? Should there be a component that reflects this potential?
A component that reflects which potential? I'm sorry?
The potential for inequitable
Palliative
access
care. To palliative care, Vanessa.
Again, I want to restate that within the resolution, RNAO has and will continue to emphasize the need for timely, effective palliative care in all of its dimensions. Evidence-based, that there are, services that provide comprehensive palliative care, that we maximize our ability to manage people in the stages, all across the stages of palliative care. Again, that's reinforced in the resolution.
Okay. Palliative care needs to be separated from euthanasia, as the public are starting to fear what we as palliative care teams offer. Much of our effort in raising the profile and pushing for palliative care access is being undermined by joining the discussion of euthanasia with palliative care.
Again, I will encourage you to actually join the Supreme Court debates. The public is not afraid of speaking. In fact, the public is speaking about all the components, including palliative care, including euthanasia, etc. It's the public that is pushing these guys.
Yeah. I was just, I just want to make a comment that it is the public who are moving these pieces. We can't stop the public dialogue. The public dialogue is already happening. And it includes euthanasia as well as palliative care. In fact, I think that another key point of RNAO being involved in these dialogues is to ensure that the palliative care piece remains as a top priority. The public's discussion right now, if you look at newspaper, if you look at online, if you look at the conversations that are happening in the media, they're speaking to euthanasia. We don't want to forget about palliative care, and that's why it's particularly positioned in this resolution.
Thank you, Vanessa. The next question is, what is RNAO's position in encouraging the public to have conversations with their families regarding advanced care planning? This resolution seems focused on assisted suicide, euthanasia, rather than the broader issue of individuals discussing with their what care they would like to receive at end of life.
I think it's within the public domain to make decisions about how they want to have those discussions. Absolutely, there might be a large cohort of people who have the kind of family support that they need to have those conversations and to support the directions that they desire. There might be many people out there who don't have that kind of family support. Some may not have a family at all. So, again, this is about a dialogue that enables the public to make their determination about these issues.
Okay. Are you saying that nurses will never be involved in the actual act? We will be expected to take care of patients who are receiving measures for assisted suicide, yes or no?
It's a question that when it will come, we will need to answer. If actually Canada moves to any type of assisted suicide and or euthanasia, like is happening with Quebec or like is happening in Belgium, in Brussels, nurses will be involved, not against their will, though. Those that are not interested in participating in supporting people that have decisions about their life, as the resolution says, cannot be obliged, should not be obliged, and RNAO will insist on that. But to say that nurses will never be involved when some nurses may be wanting to accompany a patient, if that becomes legalized, then it will be responsible for us to say that. I don't think about that at that point.
Next question. How come we limit to competent adults? What about minors or individuals who are mentally incapable to make this decision?
So those are the type of frameworks of why RNAO needs to be involved. It's not only about minors, it's about people with disabilities, et cetera, that there need to be protective frameworks, yet respecting, in the case of adults with disabilities, respect also their views and autonomy.
Okay. Although you've stated that no healthcare provider should be compelled to participate, this has not been the case with abortion. Nurses are coerced into participating. It is made a job requirement even when it really is not.
It's made a job requirement?
Even when it really is not.
Well, again, I think if you want to go back to consider ethical considerations, if you want to look to your standards of practice, if you want to look to your opportunity to practice in an area where certain practices that you do not value or against your own principles. There are other opportunities even within the current context that that would allow you to live to your own values.
Thank you, Vanessa. I'll read the next comment. As an RN, I believe we need to help people through the end-of-life dying process. But at the same time, as a nurse, I believe it is important to promote conversations around end-of-life care before this becomes the issue at hand. In addition, assisting family and the person dying, they need to realize the dying process has closure for patients and their family. Identifying with the family and those individuals who are in the end stages of life, ways to help others to live life when the end is near. I have been at the bedside where by comfort and decreased pain is the practice of palliative care. This should not be confused with assisted suicide.
Correct. They should not be confused, and we fully agree. It's two different things.
Okay, the next
and I'm pretty sure that most people don't confuse them.
The next comment, if an organization could decide not to provide this service, terminally ill patients would be required to travel to other towns. This would reduce access to a necessary service.
That is correct, and that's the case also with abortions.
Next question. How and when will we approach this issue with the Supreme Court?
We will not approach it with the Supreme Court. The Supreme Court process is already going on. RNAO has no intervener status on it. All we are urging is actually a public debate, and that's happening as we speak.
This is a comment. The values and beliefs of all stakeholders must be respected, and acceptance of the patient's choice must also be respected. Participation in the act of assisted suicide is a moral conflict that the healthcare provider needs to resolve for themselves. It is a matter of choice for all. Next question. If the Supreme Court decides against assisted suicide / active euthanasia, will RNAO continue to explore this issue with the public and profession?
Yes, in the sense that we will continue to urge public debate on the issue of end of life, which includes all the aspects of palliative care.
Okay. Just wondering if RNAO has a stance or position regarding end-of-life care and the opportunity for tissue and organ donation.
Yes, on the issue of tissue and organ donation, we not only have been very supportive of that, but actually we had a representative of RNAO in the initiative of the Trillium end-of-life gift, and that person participated for many years, and we supported that very much and was written in the RNJ.
Okay. Since nurses work in an interprofessional team, can you comment on how our other professional colleagues in Ontario and across Canada have responded to this issue?
Yes, and we certainly can send you the latest of the Canadian Medical Association which is encouraging the court, the Supreme Court of Canada, to allow physicians to make decisions with patients.
Okay. Actively assisting with...
And sorry, if I may, we are also very involved with the OMA in the discussions on end of life, and I have been invited to participate in their dialogues. And of course, their first priority always is also the issue of accessible palliative care everywhere for every person.
Okay. Actively assisting with death goes against foundational healthcare principles in Canada. How could there be assurances that this is not the first step toward involuntary euthanasia? Palliative care is dying with dignity.
Well, I would encourage the colleague that sent that comment to follow, please, the Supreme Court of Canada case. I think will be very informative and answer a lot of the dilemmas that you are expressing.
The title of the resolution is rather problematic, RN Voice in National Discussion Regarding End-of-Life Care. It conveys that this resolution is inclusive of registered nursing voiced opinion across the country and across this province. I am very confused that we continue to say that the resolution of these issues lie in the hands of the public. I would suggest that this resolution is unhelpful and in fact confusing for the public even. If we do not clarify definitions in this resolution, how are we advocating for the public?
It doesn't say RN, it says RNO, and this is about RNO. RNO is doing this webinar, and this is a resolution from the board, and we represent RNs, NPs, and nursing students. And it has all the components, including the backgrounder, and obviously all these questions came and were debated at the AGM. Vanessa, I don't know if you want to add anything to that.
Just that this resolution is, is within RNAO, and it's not a resolution that you send out to the public. Its intention is not a communication to the public. Its intention is to support and to advocate for the public.
Thank you, Vanessa. The next question. How does the idea of assisted suicide for the disabled on the basis of equality tally with the treatment attempts suicide and fails?
I'm not following the question.
I didn't hear that full question, sorry.
Sorry, let me try to reword it a bit. How does the idea of assisted suicide for the disabled on the basis of equality
I don't want to rephrase because I am not understand. I am reading it as you, and I don't understand the question.
Okay, should I move on?
Yeah, they can rephrase the question and resend the question. I don't want to attempt to guess what the person is trying to say.
Sure. Okay, so if the sender of that question could rephrase it to be clearer, that would be appreciated. I'll move on to the next comment. There were two very similar comments from two different submitters. The first one is, I agree that this is an issue that needs to be discussed. I am glad to see that we are asking the public to get involved. The second comment is, congratulations on the development of this resolution. It's a very difficult task. Well done.
Thank you very much. And we thank the members also, the ones that have, all the comments, the dilemmas, and all the issues that you're presenting. This is exactly the type of dialogue that we would love to see, not only amongst nurses, but at the public level.
Okay. Next question. How can we advocate for our clients and patients to be heard under this public voice discussion?
I think they are being heard as we speak. Again, I am not sure how many of you have followed the proceedings of the Supreme Court of Canada. I have, that they are quite fascinating. And also what's happening outside of the Hill is fascinating, with groups of people demonstrating their views, there, and a room packed inside and outside. So I think the public is engaging. In fact, again, as Vanessa said, the public is the one that is pushing these issues. And that's what André Picard's column actually said a couple of days or weeks ago, I don't know, for some of you, if you follow my tweets, and thank you, Vanessa, for reminding people. I tweet about everything that is important to RNO or that is coming across my desk that I think nurses need to know. But Andre Picard did a very good column raising many of these questions and saying the public is ahead of everybody else. And I added to it CRNO resolution because it adds to the issues of frameworks that is critical to include, right?
Okay. Has the RNAO contacted other jurisdictions, such as Oregon and European countries, to learn about their nurses' experiences and concerns?
Yes, I have. In fact, we were invited by the Belgium nurses to speak with their minister and their people in general there and their nursing council about BPSO, Best Practice Spotlight Organizations, and in the process, of course, of doing that, which they brought us as a guest, and the minister was fascinating, the woman that is the minister there. We asked many questions because, as you know, they do have a registry. And they are the ones that also is very well known that their palliative care budget was increased threefold through the discussions by the public about the difficult issues of assisted suicide and or euthanasia, which the public there was Let me also share your question a very important fact. Belgium does have a registry, and if you think that people rush to register, that's actually not the case. It's not a lot of people that rush to register, but the choice is there, and it's on their own terms of the person that has the terminal illness. They get a very, very, very thorough assessment by 3 different psychiatrists, and at the end of the day, it's a joint decision, and they need to be approved. But it's not a lot of people. So what is a lot, though, is that the palliative care funding went up 3-fold, and that more and more people are able to get adequate palliative care across all the sectors and corners of Belgium. So that's very encouraging, that aspect. And yes, you will see in April at the AGM that Belgium is going to become a VPSO. We'll have opportunity to speak with some of their people yourself.
Thank you, Doris. In the absence of a statement from RNAO regarding taking a position on the topic of pro or con assisted suicide and euthanasia, is there any guidance for members to take during the public debate on the issues? I anticipate some groups will be looking to us to help determine the direction this is going in.
Mm-hmm. I think one of the first things to do is to look at the resolution and look at the principles that were voted on and approved by the membership. I think those are some of the foundational ingredients that will support the conversations.
Thank you, Vanessa. The next submission is a comment. The public may be discussing the issue of assisted suicide, but it is because for many individuals the access to palliative care is not available. People are afraid because of the lack of access to excellent palliative care.
And that's why we need to support and continue to support effective access, timely access, expanded access to palliative care.
What steps is RNAO to document the concerns and suggestions that are being brought forward in this webinar?
We are actually capturing that so that we can include and integrate that as we move forward with dialogues. And let's be reminded that not only have heard concerns, we also have heard many thank yous for taking this on and speaking on this and having a voice at the table, which is essential, and equally and most importantly, the debate and decision that was made at the AGM by the voters.
The public currently lacks understanding and availability of palliative care. How can we best communicate the need for widespread availability of palliative care for all Canadians?
Excellent comment, and this will be at the top of our priority if and when we are invited to speak on this. And this also is, of course, included in our best practice guideline.
If the criminal code is revised, how will we as nurses prevent abuse, which will be inevitable?
Well, I would first start with the end of that comment. It will not be inevitable. In fact, it is completely avoidable. This is what's happening in Belgium, and no one is taking advantage of that. And hence why we need principles and parameters if and when the issue of assisted suicide and or euthanasia are discussed. And we put some of those parameters for you in the resolution that was passed. And when the time comes, if the discussion will happen, is when we will work some of those more in detail. And I'm certain that we will not be the only ones raising those issues and trying to put clear parameters and protective frameworks. So will be doctors, so will be the public. The public also has no intention, whether they support or don't support the issues of assisted suicide and or euthanasia. They have no intention of abusing that, and certainly those that will develop, if we get there, those that will develop legal frameworks also be very, very thoughtful about that. So I think we need to be I think we need to give a bit more credit to the public for what we do in general, not only on this issue, but actually other issues related to health and healthcare than what we currently give.
Yeah.
We have a very mature public in Canada and a very well-educated public. And it's not only years of education, but actually life education. You know, so I think we need to be respectful also of the public debate and not assume that we always know more than them.
The next question is, how would the topic be discussed with patients and family in terms of care plan?
Too early to speak about that. Let's get there and then we will talk. If the issue of the Supreme Court of Canada is the context in Canada, that's when RNAO will need to actually be dealing with this and may include even best practice guidelines or parameters, and I'm sure the College of Nurses also will have a lot to do with that.
Thank you, Doris. The next question, how is the best way to follow the Supreme Court latest dialogue and discussion?
Television, CPAC. And also if you Google Supreme Court of Canada, every single day there have been pieces in the newspaper. But you know, I mean, that might be a piece that may be important for us to start to include in the loop. So thank you for the question. I think it's a piece that we can pass on to Marianne to include in the loop brief updates, because the decision will be made probably, usually it takes 6 months, and this is a Supreme Court that has made relatively timely decisions on issues, so I expect within 6 months we will have, so we can do updates in the loop. Thank you for raising that.
Okay. When we discussed legalizing abortion, we were told that we would not have to care for people having an abortion, but in fact, we were faced with these patients when we came on shift. How can we create a working that guarantees that the nurse will not face this dilemma in palliative care?
You know, I don't think we can discuss these things. I mean, I remember, and I was in the U.S. at the time, and I remember I was an assistant head nurse in a rehab unit when a nurse came to me and said to me, if we receive a patient with AIDS, I will not take care of that patient. I think that these are issues that the College of Nurses will need to deal with that. More than RNAO, we will have discussions, but we will collaborate with the college on those aspects. It's totally understandable that someone may not want to participate in an abortion or may not want to participate on assisted suicide or euthanasia, you know, and be not forced. That's part of the resolution. But before or I'm not sure that we can say we will not look at that patient. Is that what that patient decided at the end of the day? The day that they have the assisted suicide, we can say we're not part of it, but up to that day, it's a patient like anyone else. A patient, you know what I mean? I think these are tough issues that people will need to discuss and dialogue, and again, the college will need to give us some guidance on that too. I don't know, Vanessa, if you have something.
No, I agree. I mean, this is going to require a lot of reflection. Yeah. It is going to require a review of our standards. It will, in the context of the new legislation, there might be other regulations put in place. It will require a review of our conscience, in practice. There are no simple answers at this point until we get closer to a place of understanding what
the public
whether or not, where what the decision is.
Okay.
But I want to put, if I may, Josephine, before you read the next question, I just want to put in context the importance of this board resolution for the over 200 attendees that we have. If this resolution didn't exist, there would have been no space for you guys to be discussing these important pieces. That in itself already is important. Yes. Because the Supreme Court of Canada will move whether the nursing voice is there or not, whether RNs, NPs, or students have a voice at the table or not. So this webinar today only highlights the importance of this resolution, Vanessa, to me.
Yeah. Well, either we are part of the discussion is already going on. There will be decisions made, and either we become part of that or we're out of it, and these decisions are then made for us. So it's important, all of these issues, and these are fantastic insights that you're drawing upon today. All of these questions that you're raising are critically important when we move forward on next steps and consultation and considering all of the other parameters that will be positioned under these principles. We certainly want to be part of the conversation, and I agree that the resolution is allowing us to do this and allowing all of you to inform decisions, to inform the public policy that is important, and that is currently being discussed.
The next is a comment. As a frontline RN, I witnessed patients terrified to be admitted to hospital in case they are euthanasia.
So there is no euthanasia in Canada at this point. So I'm a bit surprised of the comment, unless it's happening behind doors. But I also have witnessed patients, and I think that's your next comment here, that are terrified by the ongoing suffering and where that leads them. I mean, patients are terrified coming to a hospital when they're very ill, period, regardless of anything. And so our role is to comfort patients in any case and any situation, and in the case of a terminal illness, to provide the palliative care that will provide them the best comfort.
Developing a therapeutic plan is, in a patient-centered fashion, is about understanding clearly what the patient wants and what the patient feels they need.
Thank you, Vanessa.
The next question, have we considered how inflicting death will affect nurses, such as post-traumatic stress disorder, etc.?
Yeah, those are issues that we will need to look, no different than we need to look on how inflicting, on how witnessing terrible suffering of a terminal illness also brings many issues to nurses. I mean, nurses that work in palliative care often say that they need debriefings after they lose a patient, because it's not that they lost the patient passed away, and they still need a lot of support to overcome that loss.
Yeah, I was, when I practiced in the emergency department, I can tell you that many times I needed support after seeing children come in who had circumferential burns. So our profession is one where we witness a lot of trauma and a lot of suffering, and I think in general we need that kind of support that helps us to cope.
Okay. Would RNAO be willing to share with the larger RNAO members the results from the Palliative Care Nurses Interest Group survey on the members of that interest group and their views on this? An interim report was submitted through the members' voices. I feel the members would be interested to hear what those who work in this line of work day in, day out think and feel on this topic.
I think that palliative care nurses newsletter, I welcome for them to publish in their newsletter. I think it is critical that all nurses be involved. This is a matter that is not only about expertise in palliative care, it's expertise in nursing overall. And all nurses need to feel empowered to have a voice on the resolution. And I think they did at the AGM. I think that's what we witnessed. Nurses from many walks of life, from many specialties, including our colleagues from palliative care, including our parish nurses interest group, all of them were involved in these discussions, and that was the beauty of the debate and the dialogue.
Okay. If we want to support better access to palliative care, should we not support additional education for RPNs to give medications that could cause deep sedation or refractory symptoms control, such as midazolam?
I think that our position on RPNs is very clear. RNs look after patients that are complex with unpredictable or unclear outcomes. RPNs take care, in our view, of the RNAO for patients that are predictable outcomes and stable.
Thank you, Doris. How do you feel about clinics and mobile units to prevent euthanasia from taking place in acute and long-term care settings, so persons will not fear admission if the criminal code is modified?
Well, again, if the code is modified, there will be protective mechanisms.
I think those sorts of models.
If someone practices against the law and not with the protective framework, it's against the law.
Yeah.
That's the case now, too.
If assisted suicide and euthanasia are passed, how does RNAO feel this may impact research on certain disease process and cures?
How will it influence research?
Yes, implicate research on certain disease process and cures.
Well, I think, research is ongoing. I'm not sure about what the question is getting at. I don't think that euthanasia will impact our ability to continue to research cures and better treatments and care for any disease condition that is currently out there.
Thank you, Vanessa. The next question, can you clarify what the next steps are to respond to this resolution?
To respond to the resolution, these type of dialogues that we have, we're not looking for a response to the resolution. The resolution is basically a direction to our NAO home office now. We are communicating with members. We are communicating with the public about the existence of our resolution. The resolution speaks about urging public debate by the federal and provincial governments. We are communicating that. At this point, we are not doing more than that. When the time comes, if the time comes that we will be asked to participate, if the code changes, that's when actually we will be doing more homework.
The next is a comment. RNAO, CNO, RPNAO all must be part of the discussion. Of course they must. However, I feel I must share very respectfully that RNAO is a be more in favor of, by not presenting a balanced perspective, by including the opposing view of promoting palliative care?
Not sure I understand the comment. Can you read it again? Maybe
Sure.
Vanessa understands the comment, I don't.
Okay, I'll read that again.
Okay.
RNAO, CNO, RPNAO all must be part of the discussion. Of course, they must. However, I feel I must share very respectfully that RNAO is appearing to be more in favor
Of what?
of, by not presenting
In
a
favor of
balance.
what?
I think they mean end of life, so assisted suicide or euthanasia, by not presenting a balanced perspective, by including the opposing view of promoting palliative care.
Respectfully, the resolution was passed at the AGM by a large majority. The discussions happened at the AGM. If the member was not present, maybe there is the tape that they can look. I don't know if there is the tape or not. But the discussion happened. A few members tried to actually even delete the piece of euthanasia and or assisted suicide. The great majority of members voted that down. That is the will of the members. It is not for Vanessa and I to change a resolution or for the board for that matter. The board had the wisdom of putting a resolution because the board thought that RNs, NPs, and nurses need to have a voice at the table on urging a public debate that the decision, not about palliative care, because we always have been supportive about palliative care, but that any discussion, given that we knew the Supreme Court of Canada was coming with the debate, that any discussion that will entertain euthanasia and or assisted suicide belongs with the public. It does not belong with RNs, NPs, and nursing students. We need to be part of it, especially because we need to put protective frameworks.
Yeah. The resolution is about ensuring that RNAO has a voice in advocating for the public and about setting the stage with some of the principles that are considered important to the members. Remember, the members voted in agreement of this resolution, which contains all of, not all, but the fundamental principles that are currently listed.
Thank you, Vanessa. Is responding to the comment regarding fear of euthanasia by patients. Their comment is, sometimes patients and families misunderstand the use of pain relief as a means of promoting death.
Yep.
Often had to educate patients and families that medications used to treat symptoms in an appropriate way after assessment. Need further education to help people understand the approach to care and relief of symptoms.
I agree that it's widespread that pain management often, even after a simple surgery, is something that is not well done. There is lots of opportunity for education on that piece as well.
Thank you, Vanessa. Does the RNAO have a framework or any recommendations for assisting in debriefing sessions for staff after a critical incident or death of a patient?
You will need to refer to end of life, last hours of care, and I wouldn't be able to respond to you because I'm not aware if it includes that part. But if it doesn't, it's something that when the member that is asking the question reviews that guideline, if it's not there, you actually will be well advised to recommend that we include that in the revisions. It may be it's already there, I just don't know.
How would the entire public of Canada be able to vote on such a debatable topic?
Well, this is why they are presenting the views and many groups are speaking to the Supreme Court of Canada. That's exactly the issue.
Public policy is always generated by a demand from the public. That's the first stage of the policy cycle, is to create a burning platform. And the politicians respond to the creation of that burning platform. And this is what the public is doing. They are demanding that there be conversation and discussion about this issue.
Thank you, Vanessa. How will RNAO ensure that any nurse does not have to participate in euthanasia against his or her personal principles or faith?
It won't be RNAO that has to enforce that. What it will be is part of our position if this conversation proceeds, and if the decision is made, then this is the reason why it is so important that we have a voice in how how the policy is developed, what the legislative framework would look like, and yep.
And we may be helped by the comment. I'm looking at the piece of the CMA, which I will retweet after this dialogue so people that want to see it can see it. Basically, the motion of the board includes the following. This motion, subsequently affirmed by the CMA Board of Directors, supports the right of all physicians within the bounds of existing legislation to follow their conscience when deciding whether or not to provide medical aid in dying. The CMA policy on medical aid in dying will be amended as a consequence. So, they are speaking also about the issue of every professional, in their case physicians, in our case nurses, following their conscience, right?
Mm-hmm.
So I think it's a good wording. So, when the time comes, the reality is the college will be doing some homework and we will need to do some homework, and that's when we will look at all these other pieces and also consult with our board and members.
Will RNAO push for palliative care education in all undergraduate nursing curricula in support of Canadian Association of Schools of Nursing?
I would say yes, and I would suggest to the member to absolutely put a resolution to the AGM if they so wish. Now is the time for resolutions, guys.
I was told that only 33 nurses were at the AGM to vote to speak to these resolutions.
130. So that number is incorrect. The number of, I don't think they're called voting delegates. In fact, I know they're called
consulting representatives.
Consulting representatives. I believe it was 130, and I think 12 people voted against the resolution and the rest in favor. But we can give you the exact numbers. But certainly was not 33. That's incorrect. There maybe the person that you heard was referring to the dialogue the night before, which I think was a smaller group of 30 people or so. That's probably where the confusion comes.
I would just like to let everyone know that it's now 6:45. There are 15 minutes remaining in the webinar. So,
are you posing questions, Josephine, from different people so we don't know? Very good. So everybody can answer it?
Mm-hmm.
Fantastic, thank you. And do we have a lot of more questions?
No.
Okay, so let's try to respond to all. I tip my hat for the 160-something people that are still with us. Thank you for your time, for your wisdom, for your comments, and for your participation.
A participant would like us to share that the Palliative Care Nurses Interest Group will be very willing to support RNAO members with resources, such as those for debriefing after death.
Fantastic, and I would suggest to our colleagues, the Palliative Care Nurses Interest Group, to again connect with the IABPG program, and you can do that through Josephine J. Moe at rnao.org to actually offer your expertise also, which I'm sure has been part already within the BPG on end-of-life care, and when that is revised again, to be consulted with you. Obviously, the people that participated in that BPG are all experts that were thought through review of the research and who has done most research, etc., etc.
On a similar note, someone asked, will there be a review or revision of the end-of-life care BPG?
I don't recall the date of that BPG, but we do revise or review and revise the BPGs about every 5 years. And of course, if things change before that, we will need to do that before that, as it happens with some other BPGs when the federal government made a priority that the RNO BPG on obesity would become a gold standard for implementation across the country, or the one on oysters, we actually moved to the head of the line those things and we revised them. So depending what happens here may be the case too.
Someone would like to share the comment that I think it is important not to forget that it is the client and or a substitute decision maker deemed competent that is making the decision in conjunction with their healthcare providers. It is similar to advocating and supporting clients who have chosen to be designated DNR.
Correct. I think that's what Vanessa was referring before when Vanessa said client-centered care means to actually put the client at the center of what's their choice.
Yeah.
Someone asks, who was on the committee that developed this resolution?
The board. It's not a committee. It's called the Board of Directors of RNO, and it's the entire board.
Thank you, Doris. Someone wants to share the comment. Excellent job. This resolution is one I stand behind. I am super pleased with the support towards the public being supported.
Thank you.
Okay. Can RNAO categorically state that a nurse will never be threatened with abandonment of her patient, as OR nurses have been when forced to participate in abortions against their will?
So what RNAO can categorically say is that that's what we have in the resolution. That's what we will advocate for. We cannot decide what the Supreme Court or the College of Nurses after that, or any other legal frameworks will do. We can only be at the table and advocate, and yes, we will advocate for that.
The Palliative Care Consultation Network would also like to extend to the nurses of Ontario the opportunity to connect with your local consultant to discuss any questions they have about this important issue.
Great.
Fantastic.
Someone says R is natural death. What we are talking about is not.
Okay. Different opinions, and all are respected. Anything else?
How will RNAO lobby political candidates to discuss the RNAO end-of-life resolution?
We will not lobby political candidates. A letter is going to the Premier and to the opposition leaders, as well as to the federal government, urging for a public debate. Anything else?
No, I think I see that some of you have submitted multiple questions and comments, so I'm going to ask that. Thank you. Okay, so sorry, let me just read a few more comments. Thank you, Doris and Vanessa, for taking on this difficult discussion and being open with us. Thank you for this dialogue in WebEx. It has been a great passion of mine, and I'm glad to have sat in on this discussion.
Thank you very much.
So I don't know, Vanessa, if you want to do closing remarks. Is
it 6? What time is it, Doris?
6:50, unless there are other questions. Other questions, I think.
If there are no other questions, just a couple of remarks. I want to thank all of you so much for taking an hour and a half of your time to have this conversation with Doris and I. It is critically important that you share with us your perspectives and your insights. This is a resolution that I think it's critical to what the essence of RNAO is, which is a voluntary organization open to its members' views, open to its opportunities to support members and what their needs are in developing healthy public policy. So many of the questions and the insights that you have raised this evening, whether whether or not they are opinions that are opposing or divergent or tough questions that we may not have the exact answer to. It all puts thoughts out there around this resolution, and I certainly thank you for your engagement and your involvement and look forward to further discussions with you as we move forward. So thank you again very, very much.
Thank you, Vanessa, for giving us the time, and thank you to all the members. I think we had well over 200 members, about 150 that stayed till the end. So thank you very, very much for sharing with us both your passions, your concerns, your satisfaction, etc., and the dialogue will continue, I'm sure, as the countries continue to dialogue on this themselves.